1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Picture a 55-year-old patient, right?
Yeah.
They just walked into the emergency department on a random Tuesday afternoon.
Yeah, totally under their own power, just, walking up to the triage desk.
Exactly. And they're complaining of some pretty profound fatigue, maybe a little indigestion.
Right, or like a nagging ache right between their shoulder blades.
Yeah. They look a little pale, maybe a little anxious. But again, they walked in, they're talking to the nurse.
Just a normal Tuesday.
Right. But then, fast forward 2 hours, that exact same patient is now in a critical care bay. They're intubated.
Oh, man.
Yeah, surrounded by an entire code team. They're pushing epinephrine, and their heart is completely failing to perfuse their body.
It is terrifying how fast it happens.
It really is. I mean, to an untrained eye, it looks like a sudden catastrophic accident, like lightning just struck them.
But that's the thing, right? When you actually look at the pathophysiology, when you look at what's happening on a microscopic level, that crash did not happen in 2 hours.
No, not at all.
That crash was, it was the culmination of a silent 40-year-long war that was raging inside their arterial walls.
Which is wild to think about.
It's the ultimate illusion in modern medicine. We call it an acute myocardial infarction or a, sudden heart attack, but there is absolutely nothing sudden about the disease process itself.
Right. It's essentially a ticking time bomb.
Exactly. The definition of a ticking time bomb. The fuse was lit decades ago, and what you're seeing in that trauma bay is just the final millisecond when the bomb actually goes off.
And the stakes for understanding that fuse, they really couldn't be higher.
No, they couldn't. If we zoom out for just a second to the macro level, cardiovascular disease is still the undisputed leading cause of death worldwide.
Yeah, the numbers are staggering.
We are looking at projections where it's expected to claim over 22.2 million lives annually by 2030. It just dwarfs almost every other cause of mortality.
Which is exactly why we are dedicating this entire deep dive to unpacking it.
Yeah.
But, we aren't just looking at this from a broad public health perspective.
Right, or like a chronic illness you manage in a primary care clinic.
Exactly. For you listening, whether you are an ICU nurse, an advanced practice clinician, or just someone who is, totally obsessed with understanding the human body at an elite level, we are putting on our intensivist hats today.
Yes, the intensivist mindset is so key here.
We are aggressively applying the Pareto principle today, right? The 80-20 rule. We want to isolate that 20% of critical, high-yield clinical knowledge that is going to give you 80% of your bedside decision-making power.
Right, for when that patient actually starts circling the drain.
Exactly. So to think like an intensivist, you have to fundamentally change your perspective, don't you?
You really do. You have to stop looking at coronary artery disease or CAD as just like clogged pipes.
Right, the plumbing analogy.
Yeah, the plumbing analogy is terrible. You have to understand CAD as a dynamic progressive failure of human physiology. At its absolute core, it's a specific, highly localized type of atherosclerosis that occurs directly in the coronary arteries.
And if we look at the etymology of atherosclerosis, it's actually pretty gross.
Oh, it's disgusting. It comes from two Greek roots, ather, which translates to gruel or fatty mush.
Fatty mush.
Great. I know, right? And scleros, meaning hard. So we are dealing with hardened, fatty mush inside the arteries.
Which sounds incredibly unappealing, but honestly, it is a perfectly accurate physical description of the pathology.
It really is.
And the reason this hardened mush matters is purely a function of hemodynamics, right?
Exactly. The heart really only has one job. It generates cardiac output to distribute oxygenated blood to every single tissue in the body. That is perfusion.
Right. But the heart is a muscle itself, so it needs its own blood supply to do that heavy lifting.
Right. And when you have this, gruel clogging the coronary arteries, the heart is essentially starving itself. It compromises its own ability to generate that cardiac output.
Which then leads to systemic, whole-body impaired perfusion.
Precisely. And we see this evolve clinically in a very specific sequence. I mean, it almost always starts out entirely asymptomatic. The patient feels totally fine.
They have no idea it's even happening.
None. But eventually, as the supply of oxygen fails to meet the demand, it transitions into chronic stable angina.
So that's the predictable chest pain, right? Like when they exert themselves, maybe mow the lawn, but it goes away when they rest.
Exactly. But the ultimate threat, the thing that lands them in your ICU, is when it crosses the threshold into acute coronary syndrome, or ACS.
Right.
That encompasses unstable angina, where the pain happens even at rest, and full-blown myocardial infarction, where the tissue is actually actively dying.
Okay, so who is in the crosshairs for this?
Yeah.
If we look at the demographics, middle-aged men have the highest initial incidence. It definitely strikes them earlier.
It does, yeah.
But women are absolutely not immune. In fact, as we're going to explore a bit later, they catch up post-menopause in a way that is incredibly dangerous and, frankly, often misdiagnosed.
Oh, heavily misdiagnosed.
Right. But before we get into the populations and demographics, I want to set down a few absolute must-know facts that are going to serve as our anchor points for this deep dive.
Let's hear them.
Okay, first, this disease process starts early. We are talking by age 20.
Which is terrifying.
Right. Second, it is fundamentally driven by endothelial injury, not just eating too much fat. And third, when an acute occlusion happens, it kills the patient because the body's natural backup system, the collateral circulation, it simply doesn't have the time to form.
And that concept of time, I mean, that is the dividing line between life and death. The difference between a patient managing a chronic condition at home for 20 years and a patient crashing in your ICU bed is literally just time.
So if we want to understand how to save that crashing patient, we have to trace this failing physiology step by step.
We have to go all the way down to the microscopic level.
Yeah, let's jump into the vessel wall battlefield, because I think most people have this mental model of an artery as just an inert plastic tube like the plumbing in your house.
Right, you pour enough grease down the sink, eventually it clogs.
Exactly. But that is completely wrong, isn't it?
Yeah.
How does a healthy, pliable artery actually turn into an occluded, hardened pipe?
Well, the plumbing analogy is really the first thing an intensivist has to unlearn. An artery is not an inert pipe. It is a highly active, dynamic, living organ.
Okay.
And the inner lining of that artery is called the intima. Now, the intima is coated with a single layer of specialized cells called the endothelium.
Right, the endothelial cells.
Yeah, and a perfectly healthy layer of endothelial cells acts as the ultimate barrier. It's completely non-reactive. So platelets, white blood cells, clotting factors, cholesterol, they all just slide right past it smoothly in the bloodstream.
It even secretes stuff, right?
It does. It secretes substances like nitric oxide to keep the blood vessel relaxed and wide open.
So it's basically like a biological nonstick pan. Absolutely nothing adheres to it.
Exactly. That's a great way to put it. But the trigger for this entire disease process, the match that lights the 40-year fuse, is injury. You scratch the nonstick coating.
And what's crazy is how many different ways you can cause that injury.
Oh, there are so many. It can be chemical, like the toxins circulating from tobacco smoke. It can be mechanical, like the sheer physical force of high blood pressure just constantly slamming blood against the arterial wall.
Or metabolic, right?
Right, from the toxic effects of hyperlipidemia or those advanced glycation end products in uncontrolled diabetes.
So we just have this constant barrage of insults. The nonstick pan gets scratched, the endothelium is injured. What happens next? Because this takes us to stage 1 of the pathophysiologic change, which the texts call the fatty streak.
The infamous fatty streak.
Yeah, and you mentioned this earlier, but it bears repeating with extreme emphasis. This early physiologic change is happening by age 20.
By 20, it's wild.
I mean, when I was 20, I thought I was invincible. I definitely wasn't thinking about my heart. So what exactly is a fatty streak, cellularly speaking?
Well, when that endothelium is damaged, it stops being a perfect barrier. The tight junctions between the cells sort of open up a little bit, and this allows lipids, specifically low-density lipoproteins, or LDLs, which are just floating by in the bloodstream, to leak through that damaged lining.
And they get trapped.
Yeah, they get trapped inside the intima, in the actual wall of the artery itself. And once they're trapped inside the wall, they undergo a chemical change. They become oxidized.
Which essentially makes them toxic to the surrounding tissue, right?
Highly toxic. The body recognizes these trapped, oxidized LDLs as foreign invaders. So the immune system sounds the alarm.
It sends in the cavalry.
Right. It dispatches white blood cells, specifically macrophages, to the site of the injury. These macrophages dive into the arterial wall and try to clean up the mess by literally eating the oxidized LDL cholesterol.
But they bite off more than they can chew.
They really do. They gorge themselves on so much fat that they become bloated and they die, transforming into what we call foam cells.
Foam cell.
Yeah. And as millions of these fat-filled foam cells accumulate, they create this visible yellow tinge inside the wall of the artery. And that is your fatty streak.
It is wild to think that the body's own immune system, trying to do its job and clean up the damage, is actually what builds the foundation of the plaque.
It is a massive biological backfire. But the clinical pearl here for the bedside provider is that this specific process, the progression of the fatty streak, it can actually be slowed down or even halted if caught early.
Oh, really?
Yeah. Treatments that aggressively lower circulating LDL cholesterol mean there's just less lipid available to get trapped in the wall, which means fewer macrophages gorge themselves, meaning the fatty streak doesn't grow.
Okay, but if we don't catch it, if the patient keeps smoking, keeps eating poorly, keeps walking around with a blood pressure of like 160/90, we move to stage 2.
Yeah, the fibrous plaque.
This is the compensation and progression phase. And the literature notes that this is clearly established by age 30.
Yeah, age 30. So how does a yellow streak of fat turn into a hardened fibrous plaque? Like, what is the failing physiology there?
So in a normal healthy scenario, when tissue is injured, the endothelium eventually repairs itself and the inflammation just resolves. But in a patient developing CAD, the insults are constant, the repair mechanism fails, the inflammation literally never stops.
It's just a chronic wound.
Exactly.
Yeah.
And the body eventually realizes that it cannot clear this toxic pool of fat and dead macrophages from the wall. So it initiates a containment protocol, it tries to wall it off.
Like trying to put a concrete dome over a nuclear spill.
That is a brilliant analogy, honestly. To build that dome, growth factors are released. These growth factors stimulate smooth muscle cells, which normally live much deeper down in the arterial wall, in a layer called the media, to migrate up into the intima, right over that fatty streak.
Wow, so the muscle cells actually move?
They migrate up, they start proliferating, and they secrete collagen. They literally build a tough, grayish-white fibrous cap right over the core of fat and dead cells. And this entire structure is now a fibrous plaque. So the fat is contained, which sounds like a win for the body, right?
Well, it's a win for containment, but it's a massive loss for hemodynamics. Because as this fibrous plaque grows, it physically pushes out into the hollow center of the artery where the blood actually flows.
So the pipe gets narrower.
Yes. The vessel lumen physically narrows. We call this stenosis. The resulting clinical finding is that the volume of blood able to flow to the distal heart muscle is significantly reduced.
So this is when a patient might actually start feeling that chronic stable angina when they try to run up a flight of stairs.
Exactly. The narrowed pipe just can't deliver enough oxygen to meet that increased demand.
I always like to visualize this using a highway analogy because it really cements the mechanical reality of what we're talking about.
I love a good highway analogy.
So think of a pristine multi-lane highway, right? That's your healthy coronary artery. The initial endothelial injury is like a crack forming in the pavement from heavy trucks or a harsh winter. Stage 1, the fatty streak, is when dirt and debris start settling deep into that crack. Then we get to stage 2, the fibrous plaque. This is like a shoddy, panicked patch job by a road crew.
Yep, they just dump asphalt on.
Exactly. Instead of fixing the foundation, they just dump a massive mound of asphalt over the debris. It creates this huge raised bump that physically encroaches on the lanes. Traffic has to squeeze and slow down to get around it. That is your reduced distal blood flow.
But importantly, traffic is still moving.
Exactly. The heart is still getting some blood.
And that distinction is vital because as an intensivist, you are trained to always ask one specific overrating question. The patient is getting worse if.
Right. What's the threshold?
Exactly. What is the threshold where this goes from a chronic annoyance to a lethal event? And the patient gets drastically, immediately worse when we hit stage 3, the complicated lesion.
The decompensation phase.
This is the immediate threat to life.
Okay, so sticking to the highway analogy, the complicated lesion is when that massive mound of asphalt suddenly caves in on itself, causing a catastrophic multi-car pileup that instantly blocks every single lane of traffic.
Zero perfusion. Nothing gets through.
So take us through the cellular mechanics of that pileup. Why does the plaque suddenly fail?
It comes down to the ongoing battle between the strength of that fibrous cap and the aggressive inflammation raging underneath it. The core of the plaque isn't just fat. It is a necrotic core full of inflammatory enzymes.
Specific enzymes, right?
Yeah, particularly matrix metalloproteinase, or MMPs. These enzymes constantly eat away at the collagen cap from the inside out, basically trying to dissolve it. At the same time, the plaque can become highly calcified and brittle.
So it's weak and stiff at the same time.
Exactly. So you have this weakened, thinned-out cap being subjected to the constant mechanical stress of blood pulsing past it.
It's like a balloon being inflated and deflated while someone rubs sandpaper on the inside.
That's horrifying, but yes. And eventually the tension becomes too much. The cap tears, the plaque ulcerates and ruptures.
And this is the moment everything changes.
This is the critical inflection point of the disease. The moment that plaque ruptures, the highly toxic, highly thrombogenic necrotic core is suddenly exposed directly to the flowing bloodstream.
And the body freaks out.
It completely freaks out. The body's coagulation cascade senses this raw, damaged tissue and interprets it as a catastrophic vascular breach. The body literally thinks it is bleeding to death internally, so it mounts a massive, aggressive clotting response to plug the hole.
Platelets rush to the site.
Platelets rush in and adhere to the exposed tissue.
But in this case, the body's attempt to heal the rupture is what actually kills the patient.
Precisely. And this is a critical intensivist deep dive into the pharmacology and the pathophysiology that every critical care nurse absolutely must understand. And those platelets hit the ruptured plaque, they activate. This activation causes a physical shape change in the platelet, which exposes specific receptors on their surface called glycoprotein I barrier receptors.
Let's hover on this for a second, because this is huge for understanding cardiac pharmacology. Yeah. What exactly is a glycoprotein I barrier receptor doing?
Think of them as biological grappling hooks.
Okay, grappling hooks.
Yeah. When the platelet is inactive, the hooks are tucked away. But upon activation at the site of the rupture, these hooks deploy. They aggressively bind to a protein in the blood called fibrinogen.
And fibrinogen's like the rope.
Exactly. And because each fibrinogen molecule can bind to multiple platelets, it creates a massive cross-linked net. This leads to explosive platelet aggregation and adhesion. It is a vicious feedback loop that rapidly builds a massive thrombus, or blood clot, right on top of the ruptured plaque.
And because the artery was already narrowed by the fibrous plaque to begin with, it doesn't take much for that new clot to completely bridge the gap.
Right. Within minutes, that enlarging thrombus can completely occlude the vessel. Total occlusion. The highway is completely shut down. The myocardium distal to that clot is suddenly completely cut off from oxygen. If that clot is not dissolved or physically removed rapidly, that cardiac tissue will undergo necrosis. It will die. And that is an acute myocardial infarction.
So if we're synthesizing this into our intensivist thinking framework, let's map it out. We start by identifying the problem, right? Atherosclerosis.
Correct.
The failing physiology progresses from endothelial damage to a fatty streak filled with foam cells, to a fibrous plaque that narrows the lumen, and finally to a complicated lesion.
Yeah. That's the timeline.
Then the immediate threat to life is the plaque rupture itself, which triggers those glycoprotein I barrier receptors, causing rapid thrombus formation and acute coronary syndrome.
Spawn.
And the intervention requires aggressive prevention early on to lower LDLs and stabilize the endothelium, but once that rupture happens, it requires immediate emergent restoration of blood flow.
And if we distill that entire pathophysiological journey into a single one-sentence clinical picture, CAD is a progressive disease of endothelial damage and lipid accumulation that steadily narrows coronary arteries, setting a silent, decades-long trap for a sudden plaque rupture and acute, life-threatening ischemia.
That is perfectly stated, which sets the stage perfectly for our next major question, bringing us to Section 2, hemodynamics and compensation.
This is where it gets really interesting.
Because if you really think about the timeline we just laid out, it creates a massive paradox.
Right.
If these fibrous plaques take decades to form, steadily narrowing the arteries by age 30, 40, and 50, why don't we just drop dead at age 35? If your main coronary artery is, say, 70% blocked for 10 years, how on earth is the heart compensating for that steadily shrinking supply of oxygenated blood?
It's wild to think about.
Right. How are people walking around playing tennis, living their lives with severely narrowed pipe?
Well, it's honestly one of the most incredible survival mechanisms in the human body. The answer lies in arterial anastomoses, which is a very technical term for what we more commonly call collateral circulation.
Collateral circulation.
Yeah. When we talk about hemodynamics, the body's prime directive is maintaining that cardiac output. When CAD slowly impairs the delivery of blood, the tissue distal to the blockage starts sending out distress signals. And the body responds with an incredibly elegant adaptation. It literally builds detours.
So if the main highway is getting backed up with that massive patch job, the body just sends out a construction crew to pave a bunch of back roads through the woods to get around it.
That is exactly what happens, but it requires very specific biological conditions to trigger it. There are two main drivers that dictate how well and how extensively a patient can actually build this collateral circulation.
Right, what are they?
The first driver is simply inherited predisposition. Some people, purely based on their genetics, have a robust capacity for angiogenesis, which is the physiological process of growing new blood vessels from pre-existing ones. Other people just do not.
And the second driver?
The second, and arguably the most crucial clinical driver, is the presence of chronic ischemia. When heart muscle receives poor blood flow over a long period of time, it enters a state of chronic, low-grade hypoxia.
So it's constantly a little bit starved.
Right. And this lack of oxygen triggers the release of a transcription factor called hypoxia-inducible factor 1-alpha. This factor then signals a release of vascular endothelial growth factor, or VEGF.
VEGF, I've seen that in the literature.
Yeah, VEGF is the chemical signal that tells the endothelial cells in nearby healthy vessels to start sprouting and branching out, growing towards the starving tissue to bypass the blockage.
Okay, let's unpack this for the bedside clinician. Why does this backroad system work so well for a 65-year-old with a 90% blockage, who only gets chest pain when he mows the lawn, but it fails completely for a 45-year-old who suddenly drops dead?
It all comes down to the speed of the occlusion. It is a race between the narrowing of the artery and the building of the detours.
A race.
Yeah. If the fibrous plaques in the coronary arteries grow very, very slowly over a period of decades, angiogenesis has the time it needs to work. The collateral circulation networks become incredibly intricate and robust.
So at rest, they're fine.
Right. At rest, the heart muscle receives a completely adequate amount of blood and oxygen through these new backroads. The patient might only feel symptoms when they dramatically increase the workload on the heart, like mowing the lawn or running, because the backroads simply can't handle high-speed, high-volume traffic.
And that is the definition of chronic stable angina. But the intensivist threat, the thing that triggers the rapid response team and puts the patient on a ventilator, is the acute occlusion, the sudden plaque rupture.
Precisely. And the clinical reasoning here is straightforward but devastating. Angiogenesis requires time.
Months or years, right?
Yes, it takes months or years to grow a meaningful collateral network. An acute plaque rupture, where that complicated lesion suddenly tears open, exposing tissue factor, activating those glycoprotein I-beta receptors, and forming a massive thrombus in a matter of minutes, that gives you absolutely zero time.
None.
There are no detours built for a sudden catastrophic landslide on an otherwise open highway.
So if a younger patient with relatively clean arteries suddenly has a minor plaque rupture that aggressively clots off, they have no collateral circulation to fall back on.
Exactly. And that is why a sudden total blockage in a younger patient, or a sudden blockage in an area without pre-existing collaterals, leads to massive, profound ischemia and rapid infarction. The tissue simply dies because it has absolutely no alternative source of oxygen.
This is such a vital concept for the bedside nurse assessing a patient complaining of chest pain. You are constantly trying to differentiate the threat level. So if we apply our intensivist thinking here, the core pathophysiology of compensation is that chronic ischemia triggers angiogenesis, creating collateral circulation to bypass slow-growing plaques.
Right.
The key assessment finding is a patient who is totally asymptomatic at rest but develops angina during high workloads when the oxygen demand exceeds what those tiny collateral vessels can supply.
Spot on.
The most dangerous complication is an acute occlusion, which gives the body zero time to adapt, leading to massive infarction. And your priority nursing action is differentiating between chronic, stable pain that resolves with rest versus acute, unrelenting pain that signals a sudden catastrophic thrombus.
And your one-sentence clinical picture for this physiological tug-of-war is this. Collateral circulation is a slow-building, life-saving detour system triggered by chronic ischemia, but it is utterly, completely useless against the sudden, total blockade of an acute plaque rupture.
Which means we cannot rely on the body to save itself once the rupture happens. We have to catch it before or intervene immediately during.
We have to step in.
And that brings us to the clinical bedside. Let's talk about assessment, differentials, and exam traps. Because identifying this disease in the real world is incredibly fraught. primarily because it does not look the same in every patient.
It really doesn't.
And the biggest, most dangerous divergence in how CAD presents is based on biologic sex. As an ICU nurse, this is an area where the textbooks often fail you, and it is a massive real-world clinical pitfall.
It is arguably one of the most critical health, equity, and diagnostic accuracy issues in cardiology today. We have to look deeply at the differences between how men and women experience and present with coronary artery disease.
Because the data is skewed, right?
Heavily skewed. Historically, almost all of our baseline data for cardiology was derived from studies on middle-aged men. Statistically, men usually experience a full myocardial infarction, an MI, as their very first major cardiac event, and they tend to present with what the textbooks still stubbornly call the classic signs. The crushing elephant-on-the-chest substernal pain that radiates up into the jaw or down the left arm, accompanied by diaphoresis or heavy sweating.
That's a Hollywood heart attack. The guy grabs his chest and falls over.
Exactly.
But women experience the onset of heart disease very differently. First of all, on average, they develop it about 10 years later than men, and their first cardiac event is much more likely to be unstable angina, severe pain at rest, without total tissue deaths, rather than a full-blown MI.
Right.
But the real trap for the clinician, the thing that leads to missed diagnoses and death, is the symptomatology.
Yes. The presentation in women is notoriously completely different. Far fewer women have those classic crushing signs. The key assessment trap that every triage and critical care nurse must have burned into their brain is that profound, unexplained fatigue is often the very first symptom of acute coronary syndrome in women.
Not just pain. Fatigue.
Fatigue. Along with that overwhelming fatigue, they frequently present with shortness of breath, upper back pain, indigestion, memory problems, palpitations, and generalized anxiety.
I mean, think about that symptom cluster. Indigestion, upper back pain, and anxiety. You are an exhausted nurse in a busy ED. A 60-year-old female patient comes in complaining of heartburn, a knot between her shoulder blades, and feeling anxious. It is terrifyingly easy to dismiss that as a gastrointestinal issue, or musculoskeletal pain, or just a panic attack.
And that lack of recognition has deadly, quantifiable consequences. Because these symptoms are categorized as atypical, they go unrecognized as cardiac in origin by both the patient themselves and the healthcare providers evaluating them.
Which leads to huge delays.
Massive delays in seeking and receiving treatment. As a direct result, women are diagnosed much later in the disease process. They are chronically undertreated with guideline-based medical therapies compared to men, and they are statistically more likely to die after their first MI.
That's heartbreaking.
It is. In fact, if we look at surgical interventions, women who undergo coronary artery bypass graft surgery have significantly higher mortality rates and more postoperative complications.
It is a systemic failure of pattern recognition. But I want to push back on the timeline aspect here, because it raises a physiological mystery for me. I have always been taught that estrogen is cardioprotective. So if women have this built-in defense mechanism, why is heart disease killing almost 10 times more women than breast cancer? Why does it remain the absolute leading cause of death in women?
It is a brilliant question, and to answer it, we have to look at the complex timeline of female hormones. Before menopause, you are entirely correct. Natural endogenous estrogen appears to be highly cardioprotective.
Okay, so it works early on.
Yeah, it heavily influences the lipid profile. It keeps HDL, the good cholesterol, high, and it keeps LDL, the bad cholesterol, low. It also helps maintain endothelial flexibility and vasodilation.
But then menopause happens.
Yes. After menopause, endogenous estrogen levels plummet. When that cardioprotective shield drops, the lipid profile undergoes a dangerous inversion. Women's HDL levels decrease, often falling to levels near those of men, while their LDL levels significantly increase.
And the vessels change too, right?
Yes. The smooth muscle in the arteries can become stiffer. Consequently, the risk for developing massive fibrous plaques and suffering an MI skyrockets, closing that 10-year gap very rapidly.
Okay, so logically, the immediate intensivist thought is, if the drop in estrogen causes the risk to skyrocket, couldn't we just give postmenopausal women hormone replacement therapy, HRT, to replace the estrogen and keep that cardiovascular protection going indefinitely?
That is exactly what the medical community thought for decades, and it is a massive, incredibly dangerous exam trap.
Right.
Yes, we assumed HRT would save hearts. But when large-scale clinical trials were finally run, like the Women's Health Initiative, the results shocked everyone. The data in our current clinical sources states unequivocally that hormone replacement therapy post-menopause does not protect women from CAD, and it may actually be actively harmful regarding cardiovascular risk.
Wait, how is that possible? If natural estrogen is protective, why is pill estrogen harmful?
It comes down to how exogenous hormones affect the coagulation cascade and inflammation. While HRT might still modestly improve the lipid numbers on paper, oral estrogen is prothrombotic.
Meaning it causes clots.
Exactly. It increases the liver's production of clotting factors. So if a postmenopausal woman already has existing silent fibrous plaques, giving her HRT might actually increase the likelihood that if a minor rupture occurs, it forms a massive, deadly clot.
Oh, wow.
Furthermore, starting HRT years after menopause might destabilize plaques that have already formed. The bottom line for clinical practice is absolute. You cannot and must not rely on HRT as a cardioprotective strategy for your aging female patients.
Wow, okay, that is a paradigm-shifting piece of clinical knowledge. Let's pivot slightly to another major assessment trap in the ICU, differentials and pattern recognition.
Always be looking for the differential.
Right. As an intensivist, you are always hunting for the look-alike condition, the thing that quacks like a duck but is actually a swan. Let's talk about the substance-induced differential.
We absolutely need to talk about the acute cardiovascular effects of illicit drugs, specifically powerful stimulants like cocaine and methamphetamine.
Okay.
These substances can produce an incredibly severe coronary artery spasm, resulting in profound myocardial ischemia, massive ST segment elevation on an ECG, and crushing chest pain.
So a 35-year-old patient rolls through the doors, clutching his chest, sweating profusely, looking like he's dying. How do you tell the difference between a patient having a spontaneous plaque rupture and a patient having a meth-induced coronary spasm?
Initially, just by looking at them, you can't. The clinical presentation mimics an acute spontaneous CAD rupture exactly. Both patients have severe ischemia. But this is where intensivist pattern recognition comes into play. You use the rule. If you see X plus Y plus Z, think blank. So if you see sudden severe chest pain, extreme sinus tachycardia, and wildly high, uncontrolled blood pressure in a younger patient who doesn't fit the typical decades-long CAD profile, you must immediately think of substance-induced coronary spasm.
Let's break down the failing physiology of that spasm. Why does cocaine or meth mimic CAD so perfectly?
It is a crisis of massive sympathetic nervous system, or SNS, overdrive. These drugs block the reuptake of catecholamines, flooding the synapses with massive amounts of epinephrine and norepinephrine.
Which just puts the heart into high gear.
Yes. This causes an extreme spike in heart rate and myocardial contractility. The heart starts beating incredibly fast and incredibly hard, which sends the heart's oxygen demand absolutely through the roof.
That's the demand side. But what about the supply side?
At the exact same time, those massive levels of catecholamines strongly activate the alpha-1 adrenergic receptors in the smooth muscle of the coronary arteries. This causes intense, sustained coronary vasoconstriction. The arteries violently clamp down.
So you have a heart screaming for massive amounts of oxygen because it's working so hard, paired simultaneously with a massive decrease in oxygen supply because the pipes just clamp shut.
Exactly. This severe mismatch can literally cause a full-blown myocardial infarction from the spasm alone, even in a perfectly clean artery without a single complicated plaque rupture.
So what is the independent nursing intervention? You can't give them a drug to break up a blood clot. If there is no blood clot, the artery is just spasming.
Exactly. Giving a powerful thrombolytic to a patient whose arteries are just spasming from cocaine is a massive error.
Yeah.
It could cause lethal bleeding for no reason. Therefore, your immediate actions are clear. You need a STAT-12-led ECG to confirm ischemia, you need cardiac biomarkers drawn to see if tissue is already dying, and crucially, you need a comprehensive urine or blood drug screen immediately to differentiate what precipitated the event. The treatment path forks drastically based on that toxicology result.
Okay, let's lock in this entire section on assessment and differentials into our mental framework. The core failing physiology here is that atypical symptoms in women stem from complex microvascular differences and postmenopausal hormonal shifts that we are only just beginning to fully understand.
True.
Meanwhile, substance-induced spasms cause ischemia via a deadly combination of massive oxygen demand and intense supply constriction.
Right on.
The key assessment finding you must watch for is the atypical triad in women: profound fatigue, upper back pain, and indigestion. The most dangerous complication in this phase is the clinician dismissing those atypical symptoms, leading to delayed treatment, massive myocardial damage, and death.
It happens far too often.
Therefore, your priority nursing action is to always maintain a high index of suspicion for ACS in female patients presenting with fatigue or GI complaints, and immediately obtain an ECG to rule it out. And finally, when you see extreme tachycardia and hypertension in a young patient with chest pain, you must differentiate the underlying cause spontaneous rupture versus substance-induced spasm using drug screens and biomarkers to guide your targeted therapy.
And our one-sentence clinical picture for this section. Assessment of CAD is an absolute minefield of atypical presentations, especially in women post-menopause, requiring the bedside clinician to aggressively look past classic textbook signs and consider devastating lookalikes like substance-induced vasospasm.
Which brings us perfectly to the next logical step in the clinical pathway. Section 4. Diagnostics, the chemistry of failing physiology. We've talked extensively about the symptoms, both classic and atypical. We know what to look for when the patient is in front of us. But what are the high-yield labs telling us about the patient's risk of imminent plaque rupture before they crash? We have to do a deep dive into the lipid panel.
The lipid panel is essentially your recon report on the chemistry of the battlefield. It tells you exactly what kind of ammunition the enemy has.
I love that analogy.
Yeah, lipids like cholesterol and triglycerides are fats. Fats do not dissolve in water, and blood is mostly water. For the body to use and transport these essential lipids, they have to become soluble in the blood. So the body wraps them in a protein shell, forming complexes called lipoproteins.
Okay, let's break down the critical numbers.
First, total cholesterol. Anything greater than 200 milligrams per deciliter is considered a red flag. It indicates a high overall burden of circulating fat.
Then we have triglycerides. These are the most common type of fat found in the bloodstream. A fasting triglyceride level greater than 150 milligrams per deciliter is dangerous. But I want to explore the why here. We always associate fat in the blood with eating greasy food. What actually elevates triglycerides?
It is a huge misconception that eating dietary fat is the primary driver of triglycerides. Yes, certain diseases like type 2 diabetes and chronic kidney disease elevate them, as do drugs like corticosteroids. But heavily, the driver is a specific lifestyle pattern. High alcohol intake, high intake of refined carbohydrates and simple sugars, and physical inactivity.
Wait, carbohydrates. How does eating a bagel or drinking a beer raise the fat in your blood?
Because of how the liver processes excess energy, when you consume high amounts of simple sugars or alcohol, your glycogen stores fill up quickly. The liver takes all that excess carbohydrate energy and converts it directly into triglycerides for long-term storage, packaging them into very low-density lipoproteins, or VLDLs, and sending them out into the blood.
So the sugar becomes fat.
Exactly. And here is the terrifying pathophysiology connection for CAD. When you combine a high triglyceride level with a high LDL level, the biochemical interaction causes the body to form a smaller, denser LDL particle.
Why does the size of the particle matter?
Because a large, fluffy LDL particle tends to bounce off the arterial wall. But a small, dense LDL particle is insidious. It slips right through those tiny gaps in the damaged endothelium much more easily.
Oh, wow.
It is also more prone to rapid oxidation once inside the wall, which, as we discussed earlier, triggers the massive macrophage response and foam cell creation. People with insulin resistance and high carbohydrate diets often have this exact deadly pattern of small, dense LDLs.
Let's focus on that LDL, the low-density lipoprotein. We universally call this the bad cholesterol. The danger zone is anything greater than 130 milligrams per deciliter. Though it is fascinating that our sources explicitly note that adults with a genetic makeup keeping their LDL naturally around 100 have remarkably low, almost non-existent rates of CAD. Why is LDL the ultimate villain of this story?
Because LDL particles contain more cholesterol by weight than any other lipoprotein, and they have a distinct high biochemical affinity for the arterial walls. They actively want to embed themselves in that damaged endothelium.
They are the building blocks.
They are the primary building blocks of the necrotic core of the plaque. That is why nearly all of our pharmacological interventions, like statins, focus aggressively on lowering LDL. If you remove the building blocks, you stop the plaque from growing.
And then on the flip side, we have HDL, high-density lipoprotein, the good cholesterol.
Yeah.
You want this number high. If it's less than 40 in men or less than 50 in women, the patient is at a significantly higher risk of an event. What makes HDL the hero of the arterial wall?
HDL performs a miraculous physiological process called reverse cholesterol transport. HDLs are dense. They contain more protein by weight and fewer lipids. I want you to visualize them as a fleet of empty biological garbage trucks circulating through the bloodstream.
Okay, garbage trucks.
When they pass by a developing fatty streak, they have the ability to literally extract excess cholesterol out of the arterial wall, load it into their protein shell, and carry it away from the arteries, transporting it all the way back to the liver to be metabolized and excreted.
That is an amazing visual. So if your HDL is low, it's not that you're creating more garbage. It's that the city council fired all the garbage truck drivers. The trash just accumulates at the site of the injury.
Exactly. A low HDL means you have lost your primary defensive clearance mechanism. But the lipid panel isn't the only diagnostic clue we look for. Our sources highlight a few other critical biomarkers that intensivists use to gauge the immediate threat level. Let's talk about CRPC reactive protein.
I see CRP ordered constantly in the ICU. It's an inflammatory marker, right?
Yes. CRP is a nonspecific marker of inflammation produced by the liver, usually in response to cytokines like interleukin-6. It rises when there's systemic inflammation anywhere in the body. If you have severe rheumatoid arthritis or a raging bacterial infection, your CRP will be through the roof.
Right.
But in the specific context of CAD screening, a chronically elevated CRP level means there is active, smoldering inflammation in the blood vessels.
And connecting that back to our pathophysiology from section 1, it's the inflammation, the matrix metalloproteinases, that causes a stable fibrous plaque to become unstable and eventually rupture. So a high CRP doesn't just mean you have plaques, it means your plaques are actively under attack from your own immune system and are at a high risk of rupture.
Precisely. High CRP equals high risk of plaque instability. It is a massive red flag. There are two other highly specific blood markers mentioned in the literature that we need to cover: lipoprotein and homocysteine.
I know lipoprotein A is gaining a lot of attention in cardiology right now. What is it?
Lipoprotein A, often pronounced Lp(a), is essentially a highly modified, genetically determined variant of an LDL particle that has a specific extra protein attached to it called apolipoprotein.
Okay, and homocysteine.
Homocysteine is an amino acid created during the breakdown of methionine, which is found in dietary protein. Chronically high levels of either of these substances act as aggressive catalysts for atherosclerosis.
How so?
They operate through three distinct deadly mechanisms. They directly damage the inner lining of the blood vessels, they actively promote the buildup of the lipid plaque, and they physically alter the coagulation cascade to make blood clots much more likely to form and harder to break down once they do.
This brings up a massive classic ICU exam trap that I want to highlight, because the logic seems so sound until you look at the evidence. We know that a deficiency in B vitamins, specifically folic acid, can cause high homocysteine levels.
Yes, it can.
So naturally, the intuitive nursing thought is, I have a patient with dangerously high homocysteine and high CAD risk. I will just collaborate with the provider to give them folic acid supplements. The folic acid will lower the homocysteine, and therefore, I have reduced their risk of a heart attack. It seems foolproof. But what do the actual clinical trials say?
It is a devastating trap. Yes, giving the patient folic acid will successfully lower the homocysteine level measured in their blood, but massive randomized research trials have shown definitively that giving folic acid supplements does not actually lower the patient's real-world risk of developing CAD or suffering an MI.
You are treating the number on the paper,
Yeah.
but you aren't changing the disease in the vessel.
Exactly. You successfully biohacked a lab value, but the cardiovascular outcome remained unchanged. We see the exact same phenomenon with another common supplement, niacin or vitamin B3.
Oh, right.
Taking high doses of niacin effectively raises the patient's HDL levels, the good cholesterol, but rigorous research shows that taking niacin to artificially boost HDL does not significantly reduce the risk of CAD and MI. The lesson for the intensivist is that you cannot just game the surrogate lab markers with supplements and expect the underlying atherosclerotic disease process to reverse.
Which is terrifying, but crucial to know. Now, we've talked a lot about lifestyle risks and how they drive these numbers, but what about when the chemistry is hardwired against you from the moment you were born? We have to talk about genetics in clinical practice, specifically a condition called familial hypercholesterolemia.
This is a scenario where the intensivist must recognize that lifestyle played absolutely no role in the patient's disease. Familial hypercholesterolemia, or FH, is an autosomal dominant genetic disorder. The most common form is heterozygous, meaning the patient inherited the mutated gene from one parent. It affects about 1 in every 500 people, which is surprisingly common.
What exactly is the gene doing wrong?
It is caused by a mutation in the LDLR gene. This specific gene codes for the creation of LDL receptors on the surface of the liver cells. Normally, these receptors reach out, bind to circulating LDL particles in the blood, pull them into the liver, and clear them from circulation.
So in FH, the receptors are defective. The liver's intake valves are broken.
That's a great analogy. Because of this defective clearance function, the patient has extremely high serum LDL levels circulating in their blood throughout their entire life, starting from infancy. Because the lipid burden is so constantly high, they develop severe, rapidly progressing atherosclerosis in their early to middle adult years.
And what if they inherit it from both parents?
In the rare homozygous form, which is much more severe, their total cholesterol levels can easily exceed 600 milligrams per deciliter.
600. That is an astronomical number. The blood must literally be saturated with fat.
What is a key clinical physical finding for these patients when you assess them at the bedside?
Because the blood is completely saturated and the liver can't clear it, the body desperately looks for anywhere else to put the cholesterol. You will often see xanthomas. Yeah, these are literal visible fatty growths appearing under the skin, often around the eyelids, or as large lumpy deposits over the tendons of the knuckles, elbows, or Achilles tendon. It is the body frantically pushing excess cholesterol out into the peripheral tissues. How do you even begin to treat that if the receptors are broken?
Lifestyle won't touch a cholesterol of 600. Treatment requires intense, aggressive pharmacological intervention. We use powerful lipid-lowering drugs, specifically a newer class called PCSK9 inhibitors.
How do those work?
Well, PCSK9 is a protein that normally destroys LDL receptors. By inhibiting that destroyer protein, we maximize whatever small amount of functional receptors the patient has left, alongside aggressive diet and exercise regimens.
Okay, let's pull all of this complex chemistry together into our intensivist framework for diagnostics. The core pathophysiology you must remember is that abnormal lipids, specifically small, dense LDLs, easily penetrate and embed in the arterial wall, while defective reverse cholesterol transport from low HDL fails to clear them, driving rapid plaque growth. Your key assessment finding is looking for those xanthomas on the skin, which indicates severe, potentially genetic hypercholesterolemia that requires immediate pharmacological intervention. The most dangerous complication identified by these labs is a high CRP combined with a high LDL, which indicates that active systemic inflammation is attacking existing cholesterol plaques, making an acute rupture and sudden MI highly likely.
Very likely.
Your priority nursing action is to ensure patients are evaluated comprehensively, not just looking at a total cholesterol number, but breaking down the specific threat of LDL over 1 in 30 and the specific deficit of HDL under 40 or 50. And your most important treatment strategy is to focus aggressively on lowering the bad LDL with proven medications, rather than falling into the trap of trying to artificially boost HDL with supplements like niacin that don't actually improve survival outcomes.
And to summarize the diagnostic chemistry in one clinical picture, diagnostics in CAD revolve around identifying the toxic biochemistry of high LDL, high triglycerides, and systemic inflammation that actively drives endothelial destruction, fuels the necrotic core, and creates a highly unstable plaque.
That sets us up perfectly for the climax of our clinical discussion, Section 5, Priority Modifiable Threats and Interventions. We've diagnosed the threat. We understand the chemistry and the cellular mechanics. As bedside clinicians managing these high-risk patients, what are the highest priority nursing problems, and exactly how do we intervene to stop the progression to ACS?
We need a plan.
Right. We're going to map this out using the classic ADP-IU framework: assessment, diagnosis, planning, implementation, and evaluation.
Starting with assessment, your priority is vigilance. You must recognize those atypical symptoms we discussed, especially in women. You must also actively utilize the validated 10-year risk calculator for patients aged 40 to 79.
What goes into that calculator?
This clinical tool synthesizes the patient's age, gender, race, tobacco use history, diabetes status, blood pressure, and lipid panel to generate a hard percentage of their risk for a major cardiac event in the next decade.
Moving to diagnosis. When we formalize the threat, the highest priority nursing problems are ineffective tissue perfusion, because the pipes are blocked, and risk for decreased cardiac output because the pump is starving for oxygen.
Which brings us to planning. In the ICU, hope is not a plan. We need hard, measurable goals. For these patients, the absolute target blood pressure is strictly less than 120 over 80. And for our diabetic patients, the target A1C is less than 7%. These are non-negotiable ceilings.
So how do we achieve them? This is the implementation phase. Let's break down the specific modifiable threat, starting with what might be the most destructive force of all: hemodynamics, respiratory physiology, and the tobacco threat. We all know smoking is bad, but biologically, physiologically, why is smoking so devastating to the human heart?
It is essential to understand that tobacco smoke is a brutal, simultaneous two-front attack on both hemodynamics and gas exchange. Let's look at the first front. Nicotine.
The stimulant.
Right. When nicotine enters the bloodstream, it acts as a powerful stimulant. It causes an immediate, massive release of catecholamines, epinephrine, and norepinephrine from the adrenal medulla.
And as we discussed with cocaine, catecholamines are the body's emergency fight-or-flight chemicals.
Exactly. This catecholamine surge causes an abruptly increased heart rate, widespread peripheral vasoconstriction, and a spike in blood pressure. So immediately upon inhaling, the heart is forced to work much, much harder against a higher resistance. The afterload increases, the myocardial oxygen demand skyrockets.
So the heart is screaming for more oxygen because of the nicotine. That's the hemodynamic threat. But what about the gas exchange threat? This is the second front of the attack.
The second front is carbon monoxide, a highly toxic gas found in high concentrations in tobacco smoke. To understand this, we have to look at the oxyhemoglobin dissociation curve. Carbon monoxide has a massive, almost 200 times greater affinity for the hemoglobin molecule than oxygen does.
200 times?
Yeah, it's huge. When it hits the bloodstream, it aggressively binds to the hemoglobin, completely hijacking those seats. This drastically reduces the number of sites available for oxygen transport.
So you have a heart muscle that is actively demanding massively more oxygen because it is being whipped by the nicotine, but the blood being delivered to it is carrying significantly less oxygen because the carbon monoxide has kicked the oxygen off the red blood cells.
It is the ultimate ischemic nightmare. High demand plus low supply equals rapid tissue hypoxia and ischemia. Furthermore, carbon monoxide is a direct chemical toxin that injures the endothelial lining, feeding right back into stage 1 of our pathophysiology, initiating new fatty streaks.
This is a question I hear all the time from patients. What about e-cigarettes or vaping? They don't have the tar or the carbon monoxide of burning paper, right? Are they a safe alternative for a patient with CAD?
Absolutely not. While the overall rate of traditional combustible cigarette smoking has thankfully decreased, the use of electronic cigarettes has exploded. And the literature is clear. Using any tobacco or nicotine product carries a severe cardiovascular risk.
Even without the smoke?
Yes. We are still waiting on the multi-decade longitudinal data for the long-term effects of e-cigs, but the immediate physiological reality is that they still deliver highly concentrated doses of nicotine. That nicotine still violently spikes catecholamines, still causes profound vasoconstriction, and still massively increases cardiac workload.
And what about secondhand smoke?
We can't forget the environmental factor. Exposure to secondhand smoke increases a completely non-smoking patient's risk for CAD by 25 to 30% because they are inhaling that carbon monoxide and those endothelial toxins.
So our implementation strategy requires aggressive smoking cessation. We don't just tell them to stop. We use targeted pharmacology. We use medications like bupropion, which is an atypical antidepressant that reduces cravings, and varenicline, which acts as a partial agonist at the nicotine receptors to blunt withdrawal, alongside traditional nicotine replacement therapy to slowly taper them off.
And the evaluation of this is incredible.
It is. Quitting smoking drops a patient's CAD risk and mortality rates significantly within just weeks to months. The endothelium starts to heal almost immediately. Okay, let's move to the next major threats: hypertension and diabetes. The shearing and metabolic threats.
Hypertension is all about the physics of shearing stress. Imagine a pressure washer constantly blasting against a fragile wall. And chronically elevated blood pressure physically damages and tears the delicate endothelium, vastly increasing the rate of atherosclerosis.
And the vessels stiffen up.
Right. As the arteries become narrowed by plaques and thickened by the smooth muscle trying to contain them, they lose their natural elasticity. They get stiff.
Which creates a terrible hemodynamic feedback loop.
Exactly. Because the arteries are stiff and narrow, the left ventricle of the heart has to pump with dramatically more force just to push the same volume of blood out into the body. This added workload follows Laplace's law. The muscle responds to the increased wall tension by growing thicker.
That's left ventricular hypertrophy, right?
Yes, LVH. The heart muscle gets dangerously thick, which actually shrinks the size of the ventricular chamber, leading to a decreased stroke volume. The heart is working twice as hard to pump half as much blood. The absolute goal is strict, unyielding blood pressure control, keeping it under 120/80 to reduce that afterload and protect the endothelium.
And what about diabetes? The numbers here are staggering. The incidence of CAD is 2 to 4 times greater among people with diabetes, even if their glucose levels are relatively well controlled. Why is sugar so destructive to the vessel wall?
Diabetes is a systemic metabolic crisis that causes profound endothelial dysfunction. High levels of circulating glucose undergo a process called glycation, where sugar molecules physically bond to the proteins in the endothelial wall, damaging them and accelerating the development of fatty streaks.
And the lipid profile gets messed up too.
Furthermore, diabetes profoundly alters how the liver handles lipids, leading to a highly atherogenic profile of high cholesterol and high triglycerides. The priority implementation is achieving and maintaining an A1C of less than 7%.
We also have to mention metabolic syndrome here because it is the unholy alliance of all these threats.
Yes. Metabolic syndrome is a cluster of risk factors fundamentally driven by underlying insulin resistance. To meet the criteria, a patient had a combination of central obesity, hypertension, abnormal lipids, and high fasting glucose.
And where the fat is stored matters, right?
Yeah. The physical presentation of that obesity matters greatly. People who store their fat deep in the visceral abdomen, giving them an apple figure, have a significantly higher incidence of CAD and worse outcomes than those who store fat subcutaneously in the hips and thighs, the pear figure, because visceral fat is highly active, constantly secreting inflammatory cytokines.
Okay, we've covered the chemical and mechanical threats, but I want to talk about the psychological state because this blew my mind when reviewing the pathophysiology, the SNS escalation. The concept of the type A versus type B personality. We use these terms colloquially all the time, but they have real, measurable cardiovascular consequences.
It's fascinating, isn't it? In clinical psychology, a type A personality is characterized as highly perfectionist, hardworking, incredibly driven, but critically, they often suppress underlying anger and hostility. They have a chronic, unrelenting sense of time urgency, and they constantly create tension in their environments. A type B personality is more easygoing, taking upsets in stride, without that underlying hostility. For decades, doctors suspected type A people had more heart attacks. But now we understand the exact physiological mechanism connecting psychologic stress directly to the sympathetic nervous system.
Right. We used to think it was just stress, but it is actual biochemistry. Chronic stress, depression, anxiety, suppressed hostility, they continually stimulate the HPA axis and the sympathetic nervous system.
Exactly. This constant low-level SNS stimulation means the patient is on a chronic endogenous drip of catecholamines and cortisol. This chronically elevates their baseline blood pressure, contributing directly to endothelial shearing injury. It chronically increases their resting heart rate and their myocardial oxygen demand.
It's literally changing their blood.
It is, but it goes deeper than that. These stress-induced hormonal mechanisms actually alter hepatic function, causing increased lipid and glucose levels in the blood, and they even cause changes in blood coagulation, making the platelets more sticky and prone to clotting. Your psychological state literally, physically changes the biochemistry and the structural integrity of your blood vessels.
That is profound. It means behavioral health is cardiovascular health.
Yeah.
Okay, let's lock in section 5 with our intensivist synthesis. We are looking at priority modifiable threats and interventions.
Let's do it.
The core pathophysiology here is that modifiable threats like smoking, delivering nicotine and carbon monoxide, hypertension generating shearing force, and chronic stress causing a steady drip of catecholamines actively destroy the delicate endothelium and create a lethal imbalance between myocardial oxygen supply and demand.
Perfect.
Your key assessment finding is proactively identifying the metabolic syndrome cluster, looking for that central apple obesity, high fasting glucose, high blood pressure, and abnormal lipids, because that combination is a massive multiplier for CAD. The most dangerous complication a patient can engage in is continuing to smoke with known CAD. It is a dual threat that simultaneously spikes oxygen demand while suffocating the hemoglobin's ability to actually carry oxygen, rapidly inducing severe ischemia.
It's the worst thing they can do.
Therefore, your priority nursing action is to establish and fiercely implement measurable goals. Target their blood pressure to less than 120/80 and target their A1C to less than 7%, intervening aggressively if they drift above those lines.
And your most important treatment is comprehensive risk factor modification, utilizing collaborative tools like smoking cessation aids such as bupropion or varenicline, alongside strict pharmacological lipid and blood pressure management.
And if we distill this complex web of interventions into one guiding clinical picture, reversing the deadly trajectory of CAD requires aggressive, highly measurable interventions aimed specifically at stopping the mechanical shearing, the chemical toxicity, and metabolic destruction of the endothelium before the plaque reaches the point of no return.
Beautifully summarized.
Okay, we have covered an immense amount of ground today. We are at Section 6, Intensivist Thinking and Summary. Let's bring all of this cellular biology, hemodynamics, and pharmacology together for the bedside clinician who is about to walk onto a 12-hour shift. How do we synthesize this massive pathophysiologic map into rapid bedside decision-making when the alarms start going off?
We use the intensivist thinking framework. You must approach every single patient complaint of chest pain or unexplained fatigue with this mental checklist.
Okay, step 1.
First, identify the core problem. The underlying problem is atherosclerosis, a progressive inflammatory plaque buildup in the coronary arteries.
Step 2.
Second, and map the failing physiology. You must visualize the timeline. We go from microscopic endothelial damage to a fatty streak full of foam cells, to a fibrous plaque that physically narrows the lumen and relies on collateral circulation, to a highly unstable, complicated lesion.
Step 3.
Third, identify the immediate threat. What is going to kill this patient on your shift today? It is not the slow narrowing. It is a sudden plaque rupture leading to an acute coronary syndrome, or MI, where the tissue factor triggers rapid thrombosis and collateral circulation cannot save the tissue because it has zero time to adapt.
Step 4.
Fourth, execute the intervention. If they haven't ruptured, your intervention is aggressive lipid management to lower LDL, strict blood pressure control under 120/80, absolute smoking cessation, and hypervigilance for atypical symptoms. If they have ruptured, your intervention is emergent restoration of perfusion.
And finally, step 5.
Reassessment. You are never done. You are constantly monitoring lipid panels, blood pressure trends, A1C levels, and cardiac biomarkers to ensure your interventions are actually stabilizing the arterial wall.
I want to highlight the clinical pattern recognition rule one more time because it is so vital for exam performance and, more importantly, bedside safety. If you see sudden severe chest pain, extreme severe hypertension, and profound tachycardia in a younger patient, you must think of a substance-induced coronary spasm driven by something like cocaine or meth, and you must immediately do a SAT-12 lead ECG, draw cardiac biomarkers, and order a comprehensive drug screen to differentiate this sympathetic overdrive from a spontaneous CAD plaque rupture.
That is exactly how an elite intensivist thinks. You are always anticipating the worst-case scenario, you are identifying the look-alike condition, and you have the diagnostic tools queued up and ready to rule it out immediately.
Let's do our final ultimate summary for this entire deep dive. Let's build a final case study in our minds. If you take absolutely nothing else away from this session, I want you to remember these 5 physiological realities to guide your practice.
The top 5.
First, the core pathophysiology of this disease is a 40-year war. Endothelial injury attracts oxidized lipids, which are consumed by macrophages to form a fatty streak as early as age 20. This evolves into a collagen-covered fibrous plaque by age 30, which can ultimately ulcerate and rupture as a deadly complicated lesion.
Yes.
Second, your key assessment finding is that women often present completely atypically. They will not always clutch their chest. They present with profound fatigue, upper back pain, and indigestion. If you miss this, you dangerously delay life-saving care.
Do not miss it.
Third, the most dangerous complication in this entire disease pathway is the plaque rupture itself. It leads directly to glycoprotein IB, a receptor activation on the platelets, causing rapid, massive cross-link thrombus formation and total acute occlusion of the artery.
That's the kill switch.
Fourth, your priority nursing action is to recognize those atypical signs of ACS early. Do not wait for the classic crushing chest pain to validate your suspicion, and actively strictly manage the modifiable risks like blood pressure, blood glucose, and smoking before the rupture happens.
Prevention is key.
And fifth, the most important treatment is relentless risk factor modification. Aim for an LDL under a 130, a blood pressure strictly under 120/80, and an A1C under 7%. You have to control the chemistry to save the anatomy.
And if I can give you the ultimate one-sentence clinical picture to carry with you on your next shift, coronary artery disease is a progressive, decades-long disease of endothelial damage, macrophage infiltration, and lipid accumulation that steadily narrows the coronary arteries, often silently masked and compensated for by collateral circulation, right up until the catastrophic moment a sudden plaque rupture causes acute, total, life-threatening ischemia.
Incredible. Thank you so much for taking this highly clinical deep dive with us today. We put on the intensivist hats. We got deep into the weeds of the macrophage chemistry, the hemodynamics of collateral vessels, the terrifying pharmacology of cocaine spasms, and the absolute bedside priorities for catching atypical presentations. Hopefully you feel armed with that critical 80-20 clinical reasoning to anticipate the crash before it happens.
I want to leave you with one final provocative thought. We talked extensively today about the genetics of familial hypercholesterolemia and how up to 40 to 60% of the general genetic contribution to CAD and MI relates directly to genes controlling lipid metabolism, like the LDLR gene. We are currently working on highly advanced genetic risk stratification and CRISPR-based gene editing therapies targeting proteins like PCSK9. So here's the question for the future of cardiology to ponder. As this genetic mapping becomes cheaper, more accessible, and vastly more advanced, how long will it be until we aren't just treating 50-year-olds with statins and blood pressure meds to manage the damage, but actually treating the genes of a 15-year-old, intervening at the molecular level before the very first oxidized lipid even has a chance to form a fatty streak in their endothelium?
Imagine a medical landscape where the arterial wall never becomes a battlefield in the first place, where we turn off the disease before stage 1 even begins, something truly profound to think about. We will catch you on the next deep dive.